Obesity is not कि मुझे मोटापा है, मैं सिर्फ मोटापा हूँ. उसके साथ linked जो जुड़ी हुई बीमारियां हैं, diabetes. 80% of obese people will get diabetes, hypertension, obstructed sleep apnea, liver cirrhosis, cancers. People don't understand that obesity is the second largest cause of cancers. So bariatric surgery or metabolic surgery for obesity is basically, it's a type of gastrointestinal surgery in which we alter some part of your food mechanism. Stomach छोटा होता है, आपकी आंतों का डायरेक्शन थोड़ा चेंज होता है, primarily to change the hormonal system of your body. So people think आपका पेट छोटा कर दिया, आप खाना कम खाएंगे, वजन कम हो जाएगा. Wrong. अगर खाना कम खाने से ओबेसिटी खत्म हो जाएगी तो आप खाना कम अभी शुरू कर दो. खाना कम खाने से डायबिटीज ठीक नहीं होगी, ब्लड प्रेशर ठीक नहीं होगा. One of those hormone is a GLP-1 which has also been used for treating of diabetes. But over a period of time they realized that it had brilliant effect on weight loss too. So then they said, okay, let's also use it for obesity. It's a double-edged sword. And I see a lot of so-called celebrities talking about it that we've taken and it's a magical drug. So first of all, please understand, it is not a magical drug. It has its own side effects. Plus, you got to take it for lifelong. So these pharma companies, they don't tell this to the patient. You need to take this expensive drug for lifelong for anything between 10, 15, 20% of your price. I get a lot of patients saying, हमारी ना दिसंबर में शादी आने वाली है, मुझे लहंगा पहनना है और मेरे भाई की शादी है और मुझे डांस भी करना है. डॉक्टर साहब प्लीज थोड़ा सा ये 10, 15, 20 किलो कम करा दीजिए. They don't understand. Now these drugs when they give a scientific literature, बड़ा लिखा होता है 15-20% weight loss और छोटा लिखता है under scientific medical supervision with X amount of calories burned, with this amount of diet taken. In the last 1 decade, I would say, robotic surgery has taken a big leap towards all gastrointestinal problems also. Why? Because the movements were 360-degree movements, magnification, 3D magnification, visualization, blood loss was less.
Hi everyone, welcome to Talking Through. My name is Rahul, and in today's podcast, we have a very interesting guest with us. His name is Dr. Atul N. Peters. Currently, he is serving as Senior Director, Department of Bariatrics at Max Smart Super Speciality Hospital, New Delhi, Saket. So, without any further ado, let's meet our today's guest. Dr. Atul, welcome to Talking Through.
Thank you.
Thank you so much for your time, and it's my honor and privilege to host you. And before we deep dive into your area of specialization, I request if you can share some more details about your professional experience, then we can go ahead.
So I'm a surgeon and primarily I do all types of surgeries and I would say I do all surgeries except brain, heart and bones. So in terms of all gastrointestinal surgeries, surgery for obesity, surgery for diabetes, all hernias, gallbladders, colorectal problems, cancers. So that's my specialization. Presently, I am the principal director in Max Smart Super Speciality Hospital, and I have a team of about 11 surgeons, and 5 of them are very senior surgeons. And we do close to anything with about 150 to 200 cases a month, with a case mix of complicated cases, cancer cases, robotic cases, bariatric, which is weight loss surgery, and also metabolic surgery, which is surgery for diabetes. So that's my forte.
That's great. And sir, I like to know more about bariatric surgery or anything which is related to metabolic surgeries and robotic surgery. What kind of advancement you have seen in last 20 years of your experience and where the shift is going?
So I started my surgery about almost 30 years back, and during that time, most of the surgeries were done open surgeries, right? Of course, laparoscopy started earlier than that, but acceptance came slowly. So I'm talking about 98, 2000. That is a time when laparoscopy was still evolving. So from an open surgery, that means when you cut open the abdomen, or for cancer surgeries, when you open the patient, most of the surgeries were done like open surgeries. Then came the era of laparoscopic surgery, in which most of the surgeries got converted into laparoscopic or keyhole surgery, that or also called minimal access or minimally invasive surgery. Right? So we used to make small cuts, and with those cuts we used to have an endovision system. That means, so we put in a camera, a telescope, which is a 5 millimeter scope attached to a camera with a monitor. So we used to see on the monitor and operate. Right? So we used to make a port, right? A small 5 millimeter or 7 millimeter, put in a trocar, put in a telescope, and we could visualize everything. and we could inflate the abdomen with something called pneumoperitoneum, that is inflated gas. So there is some amount of space in there to work around. Then we had long instruments or laparoscopic instruments through which we could operate. So there was a big shift. Why? Because surgeons were used to seeing and operating, right? Now, when you are watching the screen and operating here, so you need a very good hand-eye coordination. So you are visualizing everything there, operating here with magnification, and your right becomes left, left becomes right. So it's like a fulcrum. So when I move my hand right, so instruments will move right. So it was just the opposite movement. So opposite movement, magnification, eyes there, that took some time. So there was some amount of resistance, I would say, initially, but over a period of time, people understood that laparoscopy is here to stay. So surgeons slowly and gradually adapted towards laparoscopic surgery or keyhole surgery or minimal access surgery, which stayed there for about almost, it's still one of the best form of surgical treatment, laparoscopic surgery. However, in the last 1 decade, I would say, robotic surgery has taken a big leap towards all gastrointestinal problems also. So initially, robot was used for urological cancers, right? Why? Because, like for example, prostate cancer. तो वहाँ जगह बहुत छोटी है, डीप पेल्विस में प्रोस्टेट बिल्कुल नीचे है, उसको काटेंगे, अनास्मोस करेंगे. So you were going deep down, you were doing anastomosis like this. So laparoscopy, it was very difficult. Straight instruments, it was difficult to manipulate. Possible, but it was difficult and needed a lot of expertise. Robotic surgery primarily was started with that. Why? Because the movements were 360-degree movements, magnification, 3D magnification, visualization, blood loss was less. But over a period of time, robotic surgery came for other types of surgeries also. Now, almost every other surgery which we were doing open or laparoscopic can be done robotically. The advantage is it's highly magnified. It's a 3D vision. So close to zero blood loss. Pain is much less. So in my, I would say in my field, so bariatric surgery, which is weight loss surgery, all hernias, abdominal hernias, inguinal hernias, hiatus hernia, diaphragmatic surgery, cancer surgery, colorectal surgeries are now done robotically. And of course, it gets a tremendous amount of advantage both to the surgeon and to the patient. To the surgeon, because you're sitting and doing, your back is supported, right? You get a better magnified view. You get a 360-degree movement. So suturing is easier. The movements are fine. The tremors are de-escalated. That means, let's say I'm a 70-year-old surgeon and I have I have fine tremors. So those tremors are not translated to the human body, right? And magnification is brilliant. The instrumentation is good. The energy source is brilliant. The stapling devices are brilliant. So most of the surgeries which were done open to laparoscopic have actually now turned towards robotic. It's expensive, yes, I understand. But with newer robots coming in and more indigenous robots coming in, I believe that the cost is going to come down over a period of time. But today, as we sit today, it's slightly expensive. So that's more about robotic. In terms of bariatric, I would say, when I used to do bariatric almost close to 20 years back, 80% of my patients were coming from abroad, US, Europe, Australia, New Zealand, right? Bariatric was never really picked up about 2 decades back. Now, people have started understanding that there's something called bariatric or weight loss surgery. And now actually we call it metabolic surgery, right? Why? Because we understand that obesity is not कि मुझे मोटापा है, मैं सिर्फ मोटापा हूँ, right? मुझे मोटापा है और मेरा वेट ज़्यादा है. उसके साथ linked जो जुड़ी हुई बीमारियां हैं, diabetes, 80% of obese people will get diabetes, hypertension, obstructed sleep apnea, liver, cirrhosis, cancers. People don't understand that obesity is the second largest cause of cancers. Yeah. So if a male is obese, he gets much more chances, almost 7 to 8 full chances of prostate cancer, colon cancer, pancreatic cancer. In ladies, breast cancer, uterine cancer, cervical cancers. So obesity is no longer considered as a lifestyle problem like we used to think. आज से 20 साल पहले किसी को बोलो यार हम थोड़े healthy हैं, हम थोड़ा खाना ज़्यादा खा लेते हैं, मेरा बेटा थोड़ा healthy है, चलता है, right? Now WHO has classified obesity as a disease.
Different grades.
Different. So it is disease now. Now problem initially was acceptance. सी मैं बीमारी का इलाज कराने कब जाऊंगा? जब मैं मानूंगा मैं बीमार हूँ।
Yes.
सबसे पहले तो मुझे मानना है मैं बीमार हूँ। मैं बुखार की दवा तब लूंगा जब मैं मानूंगा मुझे बुखार है।
बिल्कुल।
मैं बोलूंगा नहीं मैं थोड़ा सा गर्म हूँ,
Right,
मैं
right.
थोड़ा सा गर्म हूँ, वेदर गर्म
हाँ,
था,
हाँ, हाँ.
तो बात नहीं बनेगी। सो सबसे इंपॉर्टेंट बात एक्सेप्टेंस। एंड नाउ वी हैव सीन दैट इन द लास्ट 2 decades acceptance of obesity as a disease and other diseases linked to obesity is rising in India.
Right.
Right? And I'm very grateful, even our Prime Minister actually spoke about obesity, right?
Mhm.
So the awareness is coming. And now, so earlier people used to come, used to talk about कोई magical pill दे दो, कोई दवाई बता दो, कोई food बता दो. Now they come and they say, okay, sir, we know that you're a bariatric surgeon. We know that you do surgery for obesity. What are the options for me? So acceptance. And now because of acceptance, people do come for treatment. So bariatric surgery or metabolic surgery for obesity is basically, I would say it's a type of gastrointestinal surgery in which we alter some part of your food mechanism, right? Stomach छोटा होता है, आपकी आंतों का डायरेक्शन थोड़ा चेंज होता है, primarily to change the hormonal system of your body. So people think आपका पेट छोटा कर दिया, आप खाना कम खाएंगे, वजन कम हो जाएगा. Wrong. That's completely wrong. अगर खाना कम खाने से ओबेसिटी खत्म हो जाएगी, तो आप खाना कम अभी शुरू कर दो. खाना कम खाने से डायबिटीज ठीक नहीं होगी, ब्लड प्रेशर ठीक नहीं होगा, ओएसए ठीक नहीं होगा, cirrhotic liver ठीक नहीं होगा. So it is metabolic surgery to change some part of your hormones in the body. Thereby, these hormones have an effect of obesity and other related.
Correct. All these things are interrelated. It's
Oh,
not like
absolutely.
a simple surgery where you are just tying up your stomach and
ना
आप
ना
खाना
ना
कम खाएंगे और
ना
खाना
ना. And that is one of the reasons why, you know what, when we started obesity surgery long back, till about 30 years back, there was something called an adjustable gastric band. So हम बैंड लगाते थे, that used to be adjustable. उसमें ऑल्टर कुछ नहीं हो रहा था, उसमें we were restricting you to eat. So people, so उसका failure rate बहुत high था. Why? People used to feel hungry and they could not eat. So frustration and people used to rebound with weight. And that is one of the reasons why band actually became almost obsolete today. Very few surgeons around the world will still do band. Most of the other surgeons have shifted towards more gastrointestinal surgeries, which could be a sleeve, a bypass, and a different types of bypasses.
And there has been a lot of talk about weight loss pills, Ozempic, and various other things I have seen on social media. What's on your take on this?
So, now if you, what I said was, when we do surgery, it changes your internal hormonal system. Now, what are these important hormones which actually get altered with surgery? Two important hormones are GLP-1 and GIP. Also insulins and glucagons, right? Now, people realized, when we started doing these surgeries, we realized that a large effect of these surgeries is primarily because of these hormones. So these pharma companies and researchers started to research about different types of hormones. One of those hormones is a GLP-1, which has also been used for treating of diabetes. Now, most of these drugs, they get very rapidly damaged and consumed and metabolized by the liver, right? So they did not have a long-term or a sustained effect, right? So Novo Nordisk is one of the very old pharma company. I think it's from Norway or New Zealand. I'm not very sure. I may be wrong in that. And they started researching and they made a GLP-1 analog, which was a patent by them, right? As an oral drug called Ribosils, right? So it was primarily for use with diabetes, not for obesity. But over a period of time, they realized that it had brilliant effect on weight loss too.
Just a serendipity.
Right? Yes. So then they said, okay, let's also use it for obesity. So first oral came, and then they formed IV analogs also, right? And so Wegovy and Mounjaro. So Wegovy is basically GLP-1 analog, which is injectable form. So it's once a week. So you have, it's a pre-filled syringe. You can inject it pre-filled syringe, and you can go for 0.25, 0.51, and so forth. So you can titrate depending on the results that you get. And whereas Mounjaro is basically terpizidine, which is basically a GLP-1 and a GIP analog. So it is mixture of two hormones, right? Now, having said that, it's a double-edged sword, right? People don't understand, and I see a lot of so-called celebrities and so-called I would say, people talking about it that we've taken and it's a magical drug. So first of all, please understand, it is not a magical drug. It has its own side effects. Plus, you got to take it for lifelong, right? So these pharma companies, they don't tell this to the patient, right? You need to take this expensive drug for lifelong for anything between 10, 15, 20% of weight loss. Now, this is an expensive affair. So if I have to compare drugs vis-a-vis surgery, right? Now, drugs will give you an upper limit of about 20% weight loss, right? Surgery will give you about 80% weight loss. Drugs will give you 20% relief from diabetes and cardiovascular risk factors. Surgery will give you close to 80%. If a drug, let's say over a period of 18 months, you have consumed close to 4 to 5 lakh rupees just for taking drugs, that's one-time cost for the surgery, right? Now, surgery is one-time cost and you can reap the benefit for the next 2, 3, 4 decades, right? Drug, you have to continue taking it. So imagine the financial burden on you.
Exactly. At one side, you have like a permanent solution, almost permanent.
Almost
and next side, you
permanent
have a dependency based, which
absolutely,
and the
Now-
necessity has been created by
right?
the companies.
Yes. So this is, I think it is more pharma driven than really need driven, right?
Understood.
And people, now the newer researches are coming that out of which 20%, close to 20% of them are non-responders because of genetic factors. So 20% people will still not respond to these drugs. Second, you will only respond till about 20%. Plus, you have to take it for lifelong. And once you leave, you will rebound. Right? So people are not seeing those effects. उनको लगता है quick fix है.
Correct.
It's like, you know what you see in reel. पैसा जल्दी कैसे बनाओ? Everyone wants quick money.
Right.
मुझे काम ना करना पड़े
Mhm.
और मेरे को ढेर सारे पैसे मिल जाए.
Correct.
Right? And when government or the RBI says, don't get fooled by these so-called financial gimmicks, quick money is all sham. I say the same thing for these drugs, right? Do I use it? Yes. With caution, select subgroup of patients. Primarily for patients who have stagnation or suboptimal clinical response to surgery, I use it primarily for them, right? Using it only for obesity, for that 5-10 kgs, I get a lot of patients saying, हमारी ना दिसंबर में शादी आने वाली है, मुझे लहंगा पहनना है और मेरे भाई की शादी है और मुझे डांस भी करना है, डॉक्टर साहब प्लीज थोड़ा सा ये 10-15-20 किलो कम करा दीजिए. They don't understand. Now these drugs, when they give a scientific literature, in बड़ा बड़ा लिखा होता है 15-20% weight loss और छोटा छोटा लिखता है under scientific medical supervision with X amount of calories burned, with this amount of diet taken. Right? So people वो condition X आता है ना, बड़े सेल में क्या लिखते हैं 70% बड़ा बड़ा लिखा है और छोटा लिखा है up to.
Yes.
और उसके नीचे है on selected items. So to attract the crowd, 70% sale.
All marketing tactics.
ठीक है ना, 70% बड़ा बड़ा, ऊपर लिखा up to और नीचे लिखा on select. तो जो उनका नहीं बिक रहा उस पे 70%, जो most likely वो चाहते हैं कि आप आओ तो अंदर तो घुसो. Similarly, मैं भी सबको ये कहता हूँ कि when you see these so-called drugs, take it with a pinch of salt, right? इसको सोचो कि ये क्यों लिखा हुआ है, कैसे लिखा हुआ है. Is it actually the right thing? And you would be surprised. Of course, I will not name. I have at least 3 or 4 of my patients who have undergone surgery with me, lost weight, and now they talk on Insta that they have taken drugs and they have taken diet to lose weight. So, real world and real world में ज़मीन आसमान का फर्क है. So, if all people listening, please understand, it has to be a scientific weight loss. There is nothing called magical drugs. It has to be under supervision, clinical supervision. They all have side effects. It has to be combined with a strict diet routine and a strict physical exercise routine. So if you think, मैंने चलना नहीं है, मैंने एक्सरसाइज नहीं करनी, मैंने डाइट भी नहीं करनी और मैं एक इंजेक्शन लगाऊंगा और ये मेरा क्विक फिक्स हो जाएगा, you are in for a shock. So let's talk science and something which is backed by science.
Understood. Thanks for the advice, doctor. And I also like to understand what is the correlation between bariatric surgery and surgery for diabetes, like type 2 diabetes, how they are interrelated. And
so when we say metabolic surgery, Now, metabolic surgery can be divided largely into three subgroups, right? Now, we'll have three types of patients. Number one, patients who are obese. That means उनका BMI ज़्यादा 35 से ऊपर ज़्यादा BMI. And BMI निकालना बहुत आसान है. You can go on a Google calculator निकाल लो या weight in kgs divided by height in meter square, right? So that becomes your BMI. Now हमारा BMI पहले हम लोग कहते थे 27.5 तक 27.5 तक, उसको हम obesity नहीं कहते थे. Now we've reduced it, but because we've seen in Indians our complications, cardiovascular complications come at a much lower BMI. So beyond 25 is class 1, beyond 30 class 2, and beyond 35 is class 3 obesity. Now, so there are people who are obese, but they still haven't been diagnosed with the diabetes. They could still be having diabetes when we check them, or hypertension, or OSA, or liver diseases, and so forth, but primarily into a bucket of obesity. That's one group. So इनके लिए surgeries की जाती है, right? And these are pure weight loss, but also metabolic. Why? Because they will also work through your hormonal system, right? Then there are patients, second subgroup is patients who are obese with comorbidity. So एक group हो गया सिर्फ मोटापा, एक मोटापा प्लस जुड़ी हुई बीमारियां, डायबिटीज, हाइपरटेंशन, cardiovascular, kidney, infertility both in males and female, venous vascular disorders, and खराटे आना, OSA होना. So ये second subgroup हो गया. So मोटापे के साथ जुड़ी हुई बीमारियां. And third subgroup is thin diabetics. That means patients who have only type 2 diabetes but are not clinically obese, right? They are only class 1 obese with diabetes, right? So ये वाली जो subgroup है, this is pure metabolic surgery for diabetes. The other two groups are basically bariatric or metabolic surgery for both obesity and diabetes.
Great, great. And डॉक्टर अतुल, एक चीज़ और मैं आपसे समझना चाह रहा था कि जब आपके पास कोई भी पेशेंट आ रहा है, यू आर डूइंग द डायग्नोसिस, हाउ यू डिसाइड दैट कुछ चीज़ें देयर इज़ नो अदर क्योर, ऑपरेशन ही करना होगा, बट इन सम ऑफ द पेशेंट्स यू डिसाइड दैट इसको कुछ क्लिनिकल इंटरवेंशन, लाइफस्टाइल चेंज, बीइंग अ डॉक्टर आप वो चीज़ भी एक कॉन्शियस डिसीजन लेते होंगे. वो क्या एक इन जनरल प्रोसेस होता है, आप अपने पेशेंट्स को कैसे एजुकेट या गाइड करते हैं?
So इसमें बहुत आसान है बिकॉज गाइडलाइंस है ऑलरेडी. इसमें ये नहीं हो सकता कि मेरा मन कर रहा है मैं सर्जरी कर दूं. कई बार पेशेंट ये सोचते हैं यार ये तो सर्जन है तो सर्जरी बोलेंगे.
जैसा आपने बताया कि मेरी शादी होने वाली है, मुझे लहंगा फिट नहीं आ रहा है, आप कर दो.
तो इसको ना हम ब्रॉडली डिवाइड कर सकते हैं, ये एक पिरामिड की तरह है, राइट? सबसे पहले आएगा डाइट, लाइफस्टाइल मॉडिफिकेशन, एक्सरसाइज. सो ये सबसे ब्रॉड बेस ये है. Someone who is not ready to change or not ready to adapt to lifestyle changes, diet and exercise. Now people say, sir, आप जिम जाते सबको जिम भेजोगे? I say no. I'm not saying everyone should go to the gym. My logic is you should do some physical activity, right? Pick up something that you are going to be doing for rest of your life. Badminton करो, cycling करो, cross training करो, gym जाओ, zumba जाओ, skipping करो, भागो, right? Anything which makes you happy and which you can continue is important. So lifestyle, diet, exercise. तो ये सबसे बड़ा स्लैब ही आता है अगर हम इस पिरामिड के ऊपर जाएंगे. उसके बाद आएंगे some amount of intervention. Now intervention आएंगे either in terms of drugs, right? Like the way I said, now we have this GLP-1 and GLP-1 analogs. We can add a few drugs only and only when I've seen that the patient has adapted to these three parameters. So it's not कि आप आज मेरे पास आए और मुझे इंजेक्शन लगा दो, मैंने आपको कल इंजेक्शन दे दिया. नो. सो सबसे पहले वी विल इवैल्यूएट यू, do your basic parameters, do your nutritional profile, do your body composition analysis, see the problem areas, ask them to keep a food diary and come back to us. Now आधे पेशेंट वही नहीं करके लाते, अब लिखना पड़ेगा, उनको क्विक फिक्स चाहिए. And I always tell them, see, my approach is scientific. If you are looking for a quick fix, आप मेरे पास आओ, मैं आपको इंजेक्शन प्रिस्क्राइब कर दूंगा और आप खुश होकर चले जाओगे, ये डॉक्टर साहब बड़े अच्छे हैं, then you are coming to a wrong person. So my nutritionist, Dr. Beena, she evaluates the patient. We will do a thorough investigation of the patient. Then we need a food diary. कि आप अभी जो नॉर्मल कर रहे हो वो एक डायरी में लिख के 5 दिन का में दीजिए. We will see what are the things that you're doing right and what are the things that you need to modify. उसके बाद एक्सरसाइज शेड्यूल बनेगा, बिहेवियरल चेंजेस आएगा. इफ रिक्वायर्ड वी आल्सो हैव a psychologist who will do psychological counseling for these patients. So I would say about 20-30% of the patients will settle with this only. They don't need any more intervention, right? कभी कभी उनको ये पता नहीं होता कि ये अब सबको बोलो मैं ज्यादा नहीं खाता. Have you ever heard anyone saying मैं ड्रिंक कर रहा था तो आज गाड़ी तेज चला रहा था मोबाइल पे था इसलिए मेरा एक्सीडेंट हो गया? सुना है कभी किसी को बोलते हुए? नहीं. मैं बिल्कुल ठीक स्लो जा रहा था प्लेन में, उधर से वो आ गया, इधर से वो आ गया. सो हम भूल जाते हैं कि हमारे एरर्स क्या है. मैं 2 सूखी रोटी शाम को, 2 रात को, इतना ही खाता हूँ. और जो सुबह आप 1 कप बड़ी चाय पी रहे हो और 3 बिस्किट खा रहे हो उसको कौन बताएगा? और जो थोड़ी दाल मोठ खा लेते हो, थोड़े कुरकुरे खा लेते हो, थोड़े चिप्स खा लेते हो और जो थोड़ी सी मिठाई खा लेते हो, थोड़ा चकले खा लेते हो, 1 समोसा खा लेते हो, 1 जो टिक, वो कौन बताएगा?
Ignorance and non-acceptance again.
राइट. उसका मुझे लगता है ये ठीक है, राइट. अभी कभी कभी कुछ लोग कहते हैं सर दोपहर को जब लगता है प्रोटीन बार खा लेता हूँ. मैंने कहा उसका लेबल पढ़ा है आपने? उसमें कितने कार्ब्स हैं, राइट? उसमें 6 ग्राम प्रोटीन है. 6 ग्राम प्रोटीन तो है, जो 60 ग्राम कार्ब्स है वो कौन गिनेगा? सो हमें लेबल पढ़ना ही नहीं आता, राइट? हम लोग बड़ी जल्दी अडैप्ट कर लेते हैं. आजकल डाइट चिड़वा, डाइट नमकीन. अरे दिस नथिंग कॉल्ड डाइट नमकीन एंड डाइट चिड़वा. अगर उसमें थोड़ा फाइबर परसेंटेज बढ़ा दोगे तो अकॉर्डिंग टू एफएसआई उसका आप डाइट लिख सकते हो, राइट? तो वो मिसनोमर है, राइट? फिर डाइजेस्टिव, थोड़ा फाइबर बढ़ा दिया उसको डाइजेस्टिव कर दिया, उसके कार्ब्स तो उतने ही है, राइट? सो वी गेट फूल्ड बाय दिस थिंग. एक्चुअली पता सबको होता है बट वी गेट नहीं चलेगा टाइप्स. सो सबसे पहले आप अपनी डाइट को चेंज करेंगे, फिर एक्सरसाइज करेंगे, फिर बिहेवियर मॉडिफिकेशन करेंगे, लाइफस्टाइल चेंजेस करेंगे. सो आई वुड से 20% ऑफ माय पीपल विल फॉल इन दिस कैटेगरी. येट अनदर 20% विल फॉल जिनको जो ये कर रहे हैं रिलीजियसली बट उनका बॉडी थोड़ा रेजिस्ट कर रहा है वेट लॉस के लिए. Those are the patient in which we will need some intervention. Now, what are these intervention? It could be either drugs, oral, or injectables, or we can get balloons, right? Intragastric balloon. Now, intragastric balloon again are swallowable balloons, or you can place it endoscopically. So you do an endoscopy, you place a silicone balloon, it occupies the space in the tummy, and आपको भूख कम लगती है, आपकी gastric emptying कम लगती है, satiety better होती है, and this will still add to some amount of weight loss. They can be kept for 6 months, 4 months, or 1 year, and then they can be removed, or they can just pass out from your stool if they are swallowable balloons. So this is the next form of intervention. I would say another 20% of my patients would fall in this category. The rest 60% of the patients will fall in a category who would need a surgical intervention, right? Because they are in a category of class 2 or more obesity, right? So anyone who is class 2 or more will need a surgical intervention. It's not, I think, that's the scientific way of approaching a patient. So these patients will either undergo one or other type of surgical procedure, which can be done laparoscopically or robotically, right? And then we decide the type of procedure depending on the other comorbidities that they have. So patients with diabetes will have a different type of procedure. Patient with uncontrolled diabetes will have a different type of procedure. Patients who are having kidney disease or liver disease will have a different type. So procedure may differ, right? But surgery is one of the most, I would say, stable, standard, long-term benefit for the patient. But not for all. I would say 40% of the patients can do well with the lower things, and about 60% of them would need surgery.
Okay. And Dr. Atul, can we talk more about some nutrition part? I know you himself as a certified nutritionist, and you have talked a lot about smart nutrition and other things, how we consume protein and other things. So for our audience knowledge enhancement or just to burst some of the myths, can you share some more light on what is exactly smart nutrition? And
So, see, everyone says balanced diet. A balanced diet का मतलब ये नहीं कि balance में diet रखो, diet ले लो, right? I have seen a few of the patients, and I've also seen a few podcasts where people are talking, taking protein is rubbish. I've seen it myself. They say all doctors and all nutritionists keep on stressing about protein, 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 and it's all rubbish. You don't need so much of protein. It's not good for health. It's not good for your kidneys, and blah, blah. I think it's all rubbish. Number one, your basic structural form, human body, is proteins. Your muscles are form of proteins. Your all important structures are form of proteins. So proteins and minerals are the most essential component of your diet. right? Now, proteins, the requirement is 1 gram per kg per day, right? Now, 1 gram per kg, so let's say if I'm 60 kgs, I need 60 grams of protein every day. Now, I should divide it between 20, 20, 20 to make it a good balanced diet. Now, 20 gram of protein for a vegetarian, for an Indian vegetarian person is almost impossible. It's not easy to take 20 grams of protein, right? So लोग कहते हैं हम तो दाल खाते हैं, बहुत अच्छी बात है. तो एक कौली दाल जो पकी हुई दाल है, राइट, एक कौली दाल में पानी डाला, सब कुछ डाला आपने, कितने ग्राम प्रोटीन मिल जाएगा? 4 ग्राम, 5 ग्राम, दैट्स अबाउट इट. आपने एक दही भी खा ली, 4 ग्राम और कर लिया, फिर चावल दाल सब्जी 2 ग्राम ऐड कर लीजिए, तो एक उसमें कितना ले लिया? 10 ग्राम. डेफिसिट कितना हो गया? फिर 10 ग्राम का. यही आप लंच और डिनर के लिए, तो आपने एवरी डे यू आर गेटिंग डेफिसिट by this. So protein is very important. So my logic to my patient is, whatever you put in your mouth, question yourself, is this protein? Why? Because it's nothing called 100% protein. अगर आप प्रोटीन पे फोकस कर लेंगे तो आपके कार्ब्स और लिपिड्स तो साथ चले ही जाएंगे. सपोज अगर आपने दाल पे फोकस कर लिया, राइट, तो दाल में कार्ब्स तो चले गए, फैट चले गए, तड़का डाला तो थोड़ा फैट भी चला गया, some good fat, right? So वो तो चला ही जाएगा ऑटोमेटिकली. So अगर आप अपना खाने को फोकस कर ले कि प्रोटीन आपने लेना है तो जरूर लेना है, राइट? अब प्रॉब्लम क्या है, वेजिटेरियंस के पास ना बहुत ऑप्शंस नहीं है. अब सो कॉल आप पनीर ले लीजिए, अब ये एनालॉग पनीर का नया सिस्टम चला हुआ है, राइट, विच इज स्ट्रेंज बिकॉज इट इज लीगल इन इंडिया, राइट? यू कैन राइट एनालॉग पनीर. अब एनालॉग पनीर बेचते समय तो पनीर कोई नहीं बोलेगा, वो पैकेट पे लिख सकता है, चलो लेट्स से एवरीवन इज ऑनेस्ट एंड दे राइट एनालॉग पनीर ऑन द थिंग, राइट? अगर आप होटल में खाने जा रहे हो तो वो अपने मेन्यू में थोड़ा लिखेगा पनीर टिक्का मसाला एनालॉग, पनीर टिक्का मसाला प्योर पनीर. सो हमारे पास पनीर ही ठीक नहीं है, दूध ठीक नहीं है, तो हमारे सोर्स ऑफ प्रोटीन बचा क्या? कितनी ब्रोकली खा लेगा आदमी, कितने नट्स खा लेगा, कितना पी ले लेगा, कितना सोया खा लेगा, कितना टोफू खा लेगा, right? So in those situations, if you want, you can take protein supplements, nice protein supplements which can give you proteins. Otherwise, for non-vegetarian, it is slightly easier. So I even ask my vegetarian friends, if possible, and if there is no real religious, I would say, objection, right? At least be an vegetarian, right? Because egg is a very good source of protein. Brilliant source of, each egg will give you anything between 6 and 7 grams of protein. फिर जब आप एग लेते हो, वो कहते हैं मैं तो एग वाइट खा लेता हूँ 6. अरे एग वाइट क्यों? ईट द होल एग. दिस इज अ मिसनोवर दैट कोलेस्ट्रॉल. सो अगेन ये भी एक फार्मा कंपनी से हमने पहले बनाना स्टार्ट किया था, कोलेस्ट्रॉल कम करो, कोलेस्ट्रॉल कम करो. नाउ दे से कोलेस्ट्रॉल इज ओके, VLDL और LDL कम करो, ट्राइग्लिसराइड कम करो. सो ये पहले बहुत वो बनाया, तो कोलेस्ट्रॉल, बिकॉज हाफ ऑफ द प्रोटीन इन द एग इज इन द yolk. Almost all vitamins are in the yolk. So अगर आप yolk ही हटा दोगे और white खाओगे तो आपने उसकी आधी वैल्यूज तो खत्म कर दी. I would say not even आधी, I would say 70% वैल्यू खत्म कर दी आपने. Yes, आपने प्रोटीन ले लिया, वो भी 50%. So अगर आप एगिटेरियन हो सकते हो, बहुत अच्छी बात है. एंड द बेस्ट फॉर्म, आप दुनिया में कहीं भी हो, एग बॉइल तो खा ही सकते हो, क्लीन होगा, नाइस होगा, शेल में आएगा, बॉइल तो खा ही सकते हो. सो आई वुड से एग इज अ वेरी गुड सोर्स ऑफ प्रोटीन. सो वो करिए. अब हमारे घर में इंडियन ब्रेकफास्ट क्या है? पोहा खा लो, दलिया खा लो, चीला खा लो, पराठा खा लो, सब कार्ब है, प्योर कार्ब बेस्ड ब्रेकफास्ट. सो योर किक स्टार्ट ऑफ योर डे इज नथिंग बट कार्ब्स, राइट? सो उसको हमें चेंज करना चाहिए. थोड़े नट ले लो, पीनट बटर ले लो, राइट? ब्रेड की जगह कुछ और ले लो. फिर हम कहना चाहते हैं हम ओट्स खा लेते हैं, मल्टीग्रेन ब्रेड खा लेते हैं. These are gimmicks. These are just gimmicks, right? Don't get fooled by this. Focus on your proteins. If you're focusing on your proteins, your carbs and your fats will go in automatically. So अगर मैं थोड़ा सा फोकस कर लें कि जब मैं खाना बना रही हूँ, और अगर हमारी कोई गृहिणियाँ देख रही हैं, and if mothers are watching it or some wives who are making meals, see to it that you focus on a protein-rich meal, right? And if you can focus on a protein-rich meal, right, then rest everything becomes slightly easy. So good amount of fibers, salads, fruits, very good for vitamins, very good minerals, very good, but focus on proteins, and rest everything will become an add-on.
Understood. Thanks, doctor. And now coming back to your like core specialized field, I know along with since you're working with Max Health, you have your own practice by name.
Smart clinics.
Yes, Smart Clinics. So you are serving as director of Smart Clinics. I like to know more about what kind of latest scientific approaches you are following with respect to awareing patients, adopting new technologies, this smart way of like guiding patient what to eat, what not to eat, and how you guys are working differently.
So, as I said, we have a very scientific approach towards all diseases. Now, at Smart Clinics, we are primarily doing obesity and weight management, right? So, we have a program called Think Fit, right, which is again a scientific program for weight loss, and it's a 3 months, 6 months, and a 1 year program. So, it's not something. So, we don't believe in quick fixes कि आप आओ 5 हफ्ते में 5 किलो और 6 हफ्ते में 6 किलो. We don't do that, right? It's a very scientific program. It's led by Dr. Beena, who herself is a PhD, right? So she leads the program. She takes care of the diet. I take care of the any investigations and any supplementations, any add-ons in terms of injectables or intragastric balloons that we have to do, or surgical treatment. So it's a structured program wherein we deal with all sorts of patients who need a very little weight loss, people who need weight loss which is slightly more significant, or weight loss which is associated with comorbidities. So all surgical procedures happen at the hospital itself. We don't do any procedures there. It's primarily an outpatient clinic that we have. And otherwise, along with that, we do all other surgical consults. We do it for hernias, for gallbladders, for any GI problems, reflux problems, any anorectal problems that we have, bleeding per rectum, hemorrhoids, and so forth. So that's what we do at our clinic. But all surgical procedures we do purely at Max Hospital. Yes.
And nowadays, AI is in everything. So during your clinical practice, how you guys use AI in terms of doing some like predictive modeling or understanding patients basis on the patient history, predicting anything or changing the course of like diagnosis or other things. How you guys are actually using AI in your day-to-day work?
So in terms of diagnosing, we don't use AI for a simple reason that it gives a predictive value. It's basically a data, right? It says the probability of with the symptoms, this is what probable diagnosis is. Uh, we do use AI in terms of our robotic surgeries. So our robots are AI enabled. So it will help us, like for example, instead of me choosing the stapler, what width of the stapler, what height of the staples, what tissue thickness, they will guide us that this tissue is too thick. So in terms of stapling, so for example, when I'm doing a robotics, let's say I'm doing a bariatric surgery, right? And if I've chosen a type of staplers, and the staplers will assess the tissue and says, oh, this tissue is too thick for this type of staplers, please change the stapler. So we will have to change the stapler. Then if it sees the tissue that it is still thick, it will pause. It will say, okay, pausing for compression. So it will pause and then fire. So that's how we use AI in terms of technological advances in assisting during our surgeries, right? We also have different types of, like for example, we have indocyanide green dye. We use that dye, and during our robotic surgery, it can guide us. Okay, this is a vessel. When we do anastomosis, when we're joining two things, we can say, okay, it has good amount of blood supply, so this anastomosis is not going to leak. So we use AI in terms of during our operative work, but using it purely for diagnosis, not much, especially in our cases, because we deal with surgical cases, right? So surgical cases are more clinical, and sometimes yes, we need to do investigation in terms of CTs, MRIs, and so forth. But in terms of surgical diagnosis, not much. In terms of using AI integrated with the robotic system, yes.
Got it, got it. And Dr. Saab, can we talk more about like post-op care as well? Because I know in India and across the globe, post operations, some of the patients get very casual in terms of doing follow-ups, following the advice, taking proper rest, diet, and all. So, any advice for patients going underwent surgery?
So surgery, as I said, let's talk about bariatric surgery. Now, when I talk about bariatric or weight loss surgery, I say surgery is only 20% of the work done. 80% of the work is post-operative follow-up, right? How to use this. So I give this example very often to almost all my patients. It's like if you want to be a pianist, buying a piano is just 10% job done, right? You can buy the best of the piano. You can get operated by the best of the surgeon, right? Buying the piano doesn't make you a pianist. Buying a piano is only 10% job done. The second important thing is you need a teacher who will teach you piano. And the third important leg, like the tripod, three things, right? Surgery is only one. There's no balance. Nothing has been done. Second is having a teacher, and that's us. Me, my team will teach you how to live this surgery, right? How to get adapted, how to do your food habits, behavioral modification, exercise, everything we will teach you. But still, the balance doesn't come unless the third thing comes in. The third most important is you practicing it, right? So I can tell you do this, but I can't run for you. You have to run for yourself. I can't be doing exercises for you. You have to do the exercises for yourself. I can't be keeping the diet principles. You have to do it. So it's a tripod. Good surgery, good follow-up, and practicing what we teach you. So follow-up becomes extremely important. We follow up all our patients for 10 years. We tell them 10 years is a mandate that you have to follow with us, right? It could be online sometime for my international patient, for patients from outside Delhi, right? We do an online consult, but you have to follow up with us, right?
Yes.
And so if there's no follow-up, number one is follow-up, and number two is listen to what we say, especially in terms of supplementation. We will tell you protein supplements, we will give you vitamins, minerals, irons. You must take those supplements, right? It's important for your body. So surgery, follow-up, extremely important. So this is bariatric, but for all other surgeries too, for gallbladder, hernia, they don't require a long-term follow-up, but of course, one or two follow-ups you must do with your surgeon.
And any advice you have for any budding medical professional, anyone who is interested in pursuing their super specialization in bariatric surgery, minimal access, or interested in robotics?
So I tell all my surgeons, remember one thing. So we have about 50, 60 odd medical students. We'll have four postgraduates. We have three fellows who are postgraduates. We have two PhDs, and we have fellowship in robotic and bariatric surgery as well. I tell them one thing. Surgery is a religion, is a cult. Don't become a surgeon if you just want yet another profession, right? If you think there's a calling from God, right, become a surgeon. And in surgery, there are no second chances, right? In medicine, you could probably try a drug once, and if it doesn't work, you can still change the drug. I can't do one surgery as a trial and leave it, okay, I will do the next surgery next time. There's nothing called trial and error. Number two, you're only as good as your last surgery. You may do 100 good surgeries, but one surgery is spoiled, you're gone. Third, each knot counts. Each knot counts. One wrong knot. For you, it may be just a knot, right? But for the patient, it could mean their life. So become a surgeon only if you think you have a calling from God. And it is not, there are doctors and there's a surgeon, right? You're not a doctor, you're a surgeon. I believe, and that's my belief, I may be wrong, but that's my belief that God created this body, right? And it's only a surgeon whom he has given that right to alter something that he has created, right? So he's giving you that edge, he's giving you that right, he's giving you a responsibility to alter something that he created. If you can't do it, don't do it, right? And if you think that you've chosen a procedure for someone, and if you think that you are not going to be doing this for your family, don't do it to the patient, right? Patients are giving their life to you, right? Respect it. God has given that right to alter something that he's created. Respect it. If you think you can't do it, choose any other profession. Don't be a surgeon.
And Dr. Atul, before we wrap up, I have a couple of personal questions.
Sure. Go ahead.
So I know you hold a Limca book of record for doing 16 bariatric surgeries in a day. I like to know the story, how it happened.
So number one, it was never meant to be a record. We were doing a workshop, and we did the workshop. We still had 4 more patients to go, and after 16, I told the 17 patient, I said, guys, I'm tired. If you want, I will do it, but if it's okay with you, we'll do it tomorrow. So it was never supposed to be a record. We just did it. And once everyone was discharged and everything happened, one of my patients, they used to work for some media house, and they said, do you know that no one has ever tried this? I said, we never wanted to do it, right? So it was after the event they approached us and said, okay, can we publish it? I said, sure, you can do that.
Interesting.
And so that's how it got published. And I'm happy that they have scrapped off this category now, because someone else could try breaking it, right? And they can endanger patient's life. So I think time of surgery and number of surgeries don't matter, right? Some people say that, sir, you take 3 minutes to do a gallbladder. I say it doesn't matter how much time. I have a God gift to do a quick surgery, right? But time of the surgery should not be a parameter to judge a surgeon, right? The end result of the surgery is matter. So surgery is like painting, right? Don't try to finish a painting. Do purposeful strokes, right? And the surgery will finish. So actually, honestly, this record means nothing to me, and I don't, I don't talk about it, and I don't want anyone to think that record should be done. I don't want the new surgeons to think that they can do it quickly. Don't aim for the time. Aim for doing the right procedure.
And lastly, I know you are a fitness enthusiast. You himself, like certified fitness trainer, and you play more than 18 instruments. I like to know, even after busy schedule and other things, how you manage to pursue all these hobbies and other things. What keep you motivated all day long?
So we all have 24 hours in a day, all of us, right? It's how to manage your time. So it's time management. I also have the same time. You also have the same time. When people say I'm too busy, right? It's not busy. You need to keep yourself first, right? So if I ask someone, tell me 3 things. Like if I tell you, tell me 3 people in your life who are very important to you.
My wife, my father, and my best friend Dipankar.
Perfect. Now please hear this again. Your wife, your kid, your friend, right? You never mentioned you.
Yes.
You never mentioned you. You said my wife, my father,
Yes.
my friend. But where is my? So the problem with us is we don't keep ourselves. So my saying is keep God first. Keep God first. Keep yourself second. Because अगर मैं रहूंगा तब मेरा रहेगा ना. अगर मैं ही नहीं तो मेरा क्या? My father till I am alive. When I'm dead, there's nothing called my father, right? My wife till I'm alive. So keep God first, keep you second. So keep yourself as important as anyone else. So give time to yourself. Do something which makes you happy, rejuvenates you. When I go to the gym or any physical activity, right? Can you start when I'm lifting weights? Can I think of something? No. My mind is at total rest. So that is the time. So it is meditation for me. You want to do meditation? Do meditation. Perfectly okay. Plus, our body needs a stimulus to grow, right? And also to keep alive. After an age of 40, we have something called sarcopenia. We are losing muscle mass. To keep that muscle mass, we need to exercise. So that is the reason why I exercise, to keep myself fit, healthy, happy. Music, I think it's in my genes. It's in our family. So my son is a pianist, and he's also a violinist. He also is a graduate in tabla. And of course, he's a data scientist, but that's how my wife sings. She's an artist, she's a doctor. My daughter is a vocalist, she's a pianist and a guitarist too. I play about 15, 18 instruments. I've never learned music. I think that's a God gift to me. I play piano, I play the drum set, the saxophone, name an instrument and I can play that. So I think I feel healed when I play music. So gym and music is me time, and I feel happy doing that. And I would encourage everyone, pick up a musical instrument, learn music. It'll keep your soul happy. It'll keep you occupied, positively occupied. So, and of course, spend some time on your body, right? Keep God first, keep you second.
Dr. Atul, again, thank you so much for your time. And I really say this has been a best knowledge enhancing session for me. And I'm sure whenever we release this podcast, our audience will definitely get some benefit out of it. And I know 45 minutes, 1 hour, it's not a justifiable time to.
Yeah, we can't really talk in
Yes,
detail about robotic surgeries,
absolutely.
how robotic is the best for hernias, and how robotic has actually changed surgical. The whole field has changed. So some other day probably we will talk more in
Absolutely. Look
detail
forward
about.
for another round of
Yeah.
discussion. We will do deep dive on some of these topics.
Yes.
Till then, thank you so much, sir, for
You're
your
most
time.
welcome. Thank you so much.
Pleasure.